Hi, Joe Anderson again. Going to talk a little bit about allergy immunotherapy. Immunotherapy has been used for close to 100 years, but only over the last 40 or 50 years has it been carefully studied. We now have good, double-blind, placebo-controlled trials that prove the effectiveness of properly selected immunotherapy. For immunotherapy to be effective, the patients have to be very carefully chosen, and the mixture of allergens has to be very carefully prescribed. In order for immunotherapy to be effective, a patient must be, number one, allergic to the allergen. We find that out with allergy testing. Number two, they have to be symptomatic when they're exposed to that allergen. 50% of people allergic to ragweed or almost any other allergen don't have symptoms when they're exposed. So a really good history is very important. And then lastly, you have to prove that the patient is being exposed to that allergen. So why is it so important to know this stuff? These studies showed that for immunotherapy to be effective, you have to reach an effective dose. The higher the dose, the more effective. If you put more than about 8 allergens in a single treatment vial, you can't possibly reach doses that are effective for the majority of patients. When I started my practice here in 1982, one of the first things I did, maybe the first thing, was find out what are the important allergens in Utah. It's very different in Utah than in St. Louis, where I trained. I talked to all the well-trained allergists. I carefully researched all the available data, and I was dismayed to find that no one had carefully done pollen counts to find out what are the important allergens in this area. It wasn't easy, but I got permission from Intermountain Healthcare to get up on the top of the old doctor's office building and put up a pollen slide. I went up and collected pollen almost every day for the first 15 years I was here to find out what was important, period. We continue to do pollen counts in Intermountain Allergy. We're the only ones that have ever done systematic pollen counts. That's why we offer the highest quality allergy treatment. Another thing that was found in those studies was that injection therapy was effective, not oral or sublingual therapy. The reason for this is probably because immunity is developed in the deep lymph nodes. Allergic antibody is developed on the surfaces. There's 1,000,000 times more allergic antibody on your skin and on the surface of your respiratory tract than there is in your blood or in the deep tissues. Now, injections are less convenient, so the Europeans kept studying oral or sublingual immunotherapy. I've attended meetings for 30 years and watched the evolution of that process. They finally came up with something that looked good, and that is a sublingual tablet. The thing that makes it work is that it's very high dose, somewhere in the neighborhood of 100 times the monthly dose of what we give by injection therapy. And you hold it under your tongue as long as possible so you can get absorption, presumably, to those deep lymph nodes. So this type of immunotherapy has been accepted and is being used in Europe and other parts of the world. It is not available in the United States. This hasn't kept people from trying. They're using low-dose therapy to multiple allergens. About 2 years ago, I was the principal investigator on a sublingual grass tablet from Europe. You cannot get this tablet in the United States except in a study protocol. This was a double-blind, placebo-controlled study paid for by a pharmaceutical company that's trying to bring it to market in the United States. We used it, and that study seemed to show some effectiveness. If and when that becomes available, I'll be the first one to use it. At Intermountain Allergy, we only use proven, effective allergy treatments.